Hello, I'm Dr. Lyndon Hernandez, and let's welcome Dr. Navin Kumar from the Brigham and Women's Hospital, here to share his study, the association between an increase in blood urea nitrogen at 24 hours and worse outcomes in acute non-variceal upper GI bleeding. Welcome, Navin.
Thank you.
Could you give us a brief synopsis of your study?
Absolutely. So we were interested in looking at the change in BUN at 24 hours as compared to that at presentation to see if it could be a solitary predictor of worse outcomes in acute non-variceal upper GI bleeding. Excuse me. We fortunately have several validated assessment tools for prognosis in acute non-variceal upper GI bleeding. Most commonly used the Glasgow-Blatchford score and the AIM-65 scores, as you know. But the issue with these scores is they have multiple inputs to calculate. And a recent survey actually showed that only 30% of physicians who see acute non-variceal upper GI bleeding in their practice use these validated assessment tools. So our thought process was, is there an easier tool that would require minimal calculation that could be used by practicing physicians to prognosticate in acute non-variceal upper GI bleeding? And we were aware of the literature, which actually came from our institution, of the change in 24-hour BUN in acute pancreatitis, and knowing that both conditions are fluid-sensitive conditions requiring adequate fluid resuscitation, we were interested in looking at this same predictor, change in 24-hour BUN, in our acute non-variceal upper GI patient population.
Very good, very good. And so let us, the audience, know what your findings were. Was there any surprise findings that you may have had?
Yeah, sure. So what was what was interesting was that the moment the BUN increased at 24 hours, we found a significant increase in the rate of our composite outcome, which included inpatient mortality, inpatient rebleeding, need for surgical or interventional radiologic intervention for hemostasis, or endoscopic reintervention for hemostasis. So those patients whose BUN increased at 24 hours had almost a threefold increase risk of reaching that composite outcome compared to those patients with decreased or unchanged BUN. Of course, that trend was even higher as the absolute magnitude of the BUN increase was greater. So patients whose BUN increased actually more than 20 points had a near 9-fold increased risk of reaching the composite outcome. But again, the moment we saw that increased threshold was right at the point at which the BUN increase went from 0 to positive.
Very good. You also mentioned that these patients tend to have comorbidities, renal insufficiency, renal failure, and also many of them are in the elderly group. So how can you tie that all in your results?
Yeah, it's an excellent question. So we did look back to see, were the patients whose BUN increased, were they more likely to have underlying renal disease? And sure enough, they were. There was a much higher percentage of patients with moderate or severe renal disease by the Charleston Comorbidity Index in our group that had increased BUN compared to unchanged or decrease. However, we then did a logistic regression accounting for that renal disease, and the results persisted. Again, a threefold risk increased of experiencing the composite outcome if the BUN increased at 24 hours. The elderly component is interesting because the patients were older in the group whose BUN increased compared to those who decreased or unchanged. And what we hypothesize is that practicing physicians may be reluctant to adequately fluid resuscitate patients who are at an elderly age, given the greater risk of complications from volume overload. But our study is showing that these patients whose BUN increase, which very well may be due to under-resuscitation, have worse outcomes. So we hope this study underscores the importance of adequate fluid resuscitation in this condition.
So knowing that we have to balance the risk and benefit of hydrating these group of patients, the elderly, what would your message be for endoscopists and clinical practice who may be hesitant, as you said, in hydrating these group of patients?
That's a great question. And I think the issue is that we're getting more and more evidence that maximal medical management is really important before we send our patients to endoscopy. So we found in our own study that was recently published in GIE that patients who went urgently to endoscopy had a higher risk of complications compared to those who went later. And we hypothesize again that this may be due to under-resuscitation of these patients. So our main take-home message from this study is twofold. One, here's an easy risk score that can be calculated just in one's head with 2 data points, the BUN at presentation and that at 24 hours, which can help prognosticate for these patients at 24 hours of presentation. And 2, we really feel it underscores the importance of fluid resuscitation for these patients.
Excellent. So you were involved in the retrospective analysis of the medical records. Was there any surprise or challenges that you may want to share for other researchers who will be doing these retrospective analysis? Any advice you would have for them?
Yeah, oh, that's a really nice question. So I would say one fortunate thing we had was I did it alongside another colleague. So there were 2 people going through the charts. And that was really important because whenever you do a retrospective analysis, there are going to be discrepancies in the medical charts, and you need someone who you can discuss these discrepancies with. Mm-hmm. And so what we did was we both went through the charts, we both discussed with each other, and then if there are any issues that we found that we could not decide upon how to proceed, we would then discuss with our senior author, Dr. John Saltzman, to negotiate those issues. So I think just having more eyes on the data really helps the integrity of the research, and then always having a close relationship with your senior mentor, which we were lucky to have, to make sure that you retain the integrity of the data.
Very good. And final question would be future directions in this topic, research topic you're in. Any future directions you or your colleagues may have? Yeah,
that's a nice question. What I think is, so look, the Glasgow-Blatchford score, the AIM-65 score, what's so great about them is that they are very excellent scores for prognosticating upper GI bleeding, and they're available right at the time of presentation. The issue with this change in BUN is that we do not get that information until 24 hours into the presentation. In the first 24 hours, as you know, there's a lot that goes on into caring for these patients, including recommended endoscopy within those 24 hours. So I think the next step is to think, how do we use this score, this change in 24-hour BN, to actually influence clinical management? And so I'd be interested in pursuing some further clinical-based studies where we use the tool of the delta BUN to see, should we do different things with patients whose BUN is increased at 24 hours compared to those who are decreased or unchanged? Or should it influence the way that we triage those patients at that time? Should patients with increased BUN, should they be monitored in the ICU for an additional 24 to 48 hours as opposed to transfer to the floor? Those are the types of questions I'd like to look into.
Very good. Indeed, your marker has strong clinical implications for the community gastroenterologists. Thank you, Navin, for your time. Thank you.